The American Brain Tumor Association is pleased to welcome you back to our webinar series. Our webinar topic today is What to Know When Newly Diagnosed with Primary CNS Lymphoma. Thank you to today's webinar sponsor, Ono Pharmaceuticals, for their support of this program. My name is Umbreen Maan, Program Manager here at the ABTA, and I'm delighted to introduce our speaker. Dr. Lakshmi Nayak currently serves as Director of the Center for CNS Lymphoma within the Center for Neuro-Oncology at Dana-Farber Cancer Institute in Boston. She is an Assistant Professor of Neurology at Harvard Medical School. Her research includes the development of novel therapies through preclinical and clinical studies for management of primary brain tumors, including glioblastoma and primary central nervous system lymphoma, with particular focus on molecular targeted agents and immunotherapies. Thank you so much for joining us, Dr. Nayak. You may now begin your presentation.
Thanks, Umbreen. Thanks to ABTA and also to Ono for sponsoring this webinar. It's my great pleasure and an honor to be here and talk to you about what to expect when newly diagnosed with primary CNS lymphoma. So we'll start with the learning objectives. What I'll discuss in this presentation is to understand the diagnosis and the signs and symptoms of primary CNS lymphoma, explore the standard of care treatment options and clinical trials that we are doing in this disease, and also to recognize some of the side effects that you might experience while undergoing treatment. To begin with, the definition of what is primary CNS lymphoma, well, this is an extremely rare primary brain tumor, primary meaning that this starts in the brain or the nervous system, not elsewhere in the body. It is a type of non-hodgkins lymphoma, and this is restricted to the nervous system, so it can be in the brain, the meninges, which are the coverings of the brain, eyes, or spinal cord. And importantly, there is no concurrent systemic lymphoma in this case. We'll go through some of these aspects of the topic. We'll go through epidemiology, pathology, how patients present, and then various treatment options in the newly diagnosed setting, as well as in the recurrent and refractory setting. So as I mentioned, this is an extremely rare tumor with an incidence rate of 0.4 per 100,000 person year. The rate is slightly higher in people over 70 years of age. It accounts for only 6% of malignant primary tumors, primary CNS tumors, and only 4 to 6% of all systemic lymphomas. And it accounts for up to 1,500 of new cases in the United States every year. The median age at diagnosis is 65, and so older patients account for about half the cases. The incidence rates have been increasing in the age group of over 65 since the 2000s. Well, what are some of the risk factors when we think of cancer, and then specifically for primary CNS lymphoma? Immunodeficiency is a known risk factor. Immunodeficiency meaning when the immune system of the body is not functioning normally. And what could be the causes for this? Well, this can occur as a congenital problem that kids are born with. It's quite rare. In the infectious setting, specifically HIV and AIDS, this could be a risk factor as well. Although now with well-controlled HIV, we are seeing a decrease in the incidence of HIV-associated primary CNS lymphoma. Iatrogenic means treatment-related. So patients that have undergone an organ transplantation, like a kidney transplant or a liver transplant or heart transplant, these patients are also at risk. And then autoimmune disorders such as rheumatoid arthritis or other conditions, which also require treatments that lead to an immunosuppressive state. Quite commonly, in the immunosuppressive state, specific infection with Epstein-Barr virus infection can be found associated in primary CNS lymphoma. There's a question of environmental risk factors, and these are being investigated. Although the majority of patients that we see now have what we call immunocompetent primary CNS lymphoma, which is quite different from those that occurs from these risk factors. Let's go to pathology. Now, I won't dwell too much on this, but the majority of primary CNS lymphoma is a diffuse large B-cell lymphoma, and less than 10% account for other types of lymphomas, which could be B-cell type, like marginal zone lymphoma, follicular lymphoma, lymphoblastic lymphoma, Burkitt's lymphoma, and then a small number of T-cell lymphomas. And I'd like to mention that because the majority are diffuse large B-cell lymphomas, I'll restrict the rest of the talk discussing the treatment of diffuse large B-cell lymphoma in the brain. So what might people experience when they develop primary CNS lymphoma? And this can be a variety of clinical symptoms and neurologic signs. Most of the manifestations or the symptoms are not specific for primary CNS lymphoma or even brain tumors in general. And these symptoms can be mistaken for a number of other neurologic conditions. So it requires the physician to be quite astute in making this diagnosis. Signs and symptoms or clinical features are really influenced by the location of the tumor, the size of the tumor, and how quickly the tumor is growing. So we'll go to what are called generalized symptoms that are related to pressure in the brain or involvement of multiple areas of the brain. And the most common generalized symptoms are headaches. Some symptoms, such as nausea, vomiting, can also be seen. Occasionally, patients may have some decreased level of consciousness, so they're more asleep, they're more tired, they're sleeping for more hours a day than before. And then they could have memory problems, which we call neurocognitive dysfunction. I want to mention that because these symptoms are quite nonspecific, they should be evaluated with detailed neurologic examination and brain imaging. For example, headaches are quite common in the general population, and in fact is one of the most common symptoms that an adult sees a neurologist or their primary care physician. So not all headaches are related to brain tumors. However, many patients with brain tumors do have headaches. And what's important to note is that a new onset headache in an adult with no prior history of migraines or headaches, or a change in the quality or severity or location of prior headaches should be definitely evaluated. And then something that we always suggest to primary care doctors to pay attention to is memory loss and behavioral changes, especially in older people that can be progressive over days to weeks, should warrant attention, because this may not necessarily mean a low-grade memory loss or Alzheimer's disease. Focal symptoms are those symptoms that are in a specific area, and these occur because of the tumor's invasion of the brain or compression of the brain. So patients can have one-sided weakness or paralysis, abnormal sensation on one side of the body. There could be language disturbance. There could be difficulty with vision. There could be difficulty with coordination or balance. I'd like to mention that seizures are quite rare in primary CNS lymphoma compared to other brain tumors or even brain metastases. Based on the studies, 11 to 14% of primary CNS lymphoma may have seizures, and greater than 80% of seizures of other brain tumors present with seizures. So relatively common, but not entirely unseen. Mostly in primary CNS lymphoma, there's a gradual development of symptoms over days to weeks. However, rarely acute symptoms can be seen. And those acute symptoms are related to seizures, so the first presentation in one person may be a seizure. Sometimes these tumors can bleed, And that could cause very rapid deficits, like a very severe headache or unconsciousness. And that could be the first presenting symptoms. But again, most of the time, people develop symptoms over several days. So what are common in terms of percentages? Well, memory changes or cognitive impairment or personality changes are seen in about 60% of people. Walking disorders or balance problems are also seen in up to 60% of people. Weakness of one side of the body or sensory changes are seen in up to 40% of people. Headaches and visual changes are seen in up to a quarter of patients, and epilepsy or seizures in 12%. With regard to the location of the tumor, about 55 to 60% of patients have a single lesion in the brain, and the rest patients have multifocal disease, or they could be having multiple areas of the brain affected. The eye is involved in about 15% of patients. The spinal fluid is involved in 21% of patients, and the spinal cord is involved in only 1% of patients. What I want to emphasize is a lot of times patients ask me, is there only one tumor? What's important to note is that this is thought to be a very diffuse and invasive disease, and so we don't think of it as one location or one tumor. We think of this as involving the entire nervous system, and so the treatments are also directed in a way that every part of the nervous system will get treatment to get rid of this cancer. I just mentioned here that concurrent eye involvement, that is what is also called vitreoretinal lymphoma, is seen in up to 30% of patients, and concurrent spinal fluid involvement can be seen in 20 to 40% of patients. But isolated spinal fluid involvement or isolated ocular lymphomas are quite rare. This is a typical MRI appearance. And here you could see on the left, there's a bright area of the brain, which is actually the tumor. And this is a different sequence of the MRI, which shows how there's more extensive involvement of the brain than what you could see in this bright area on the left. And so, again, an invasive tumor that we like to treat entirely and not in only one location. Diagnosis of primary CNS lymphoma remains a challenge. And the reason it remains a challenge is because most of these tumors are located deep in the brain, where it becomes hard to biopsy. And again, there can be a risk to biopsying people who are older or have other cardiac risk factors that makes surgery harder and more challenging and dangerous. At this time, we do recommend a brain biopsy to make the best confirmation for diagnosis. We generally avoid resections or removal of the entire tumor in these cases because we know we can treat this tumor with chemotherapy. And so unlike other brain tumors, biopsies are recommended compared to resections. I mention here about corticosteroids because this remains a challenge in the community, where a lot of times patients are treated with steroids for the symptoms, and then the lesion goes away, which makes the diagnosis then difficult and challenging. If a biopsy is not possible, then we recommend spinal fluid analysis, or if the eye is involved, we recommend analysis of the eye fluid. And these also can be helpful in avoiding the risks of the biopsy. Again, important to mention that early diagnosis leads to early institution of treatment. And this is one of those brain tumors where we can actually expect neurologic recovery. And so we're always emphasizing to the community doctors to try to get the diagnosis sooner so that patients can be treated sooner and can have a full recovery and go on to live normal lives after. The International Primary CNS Lymphoma Collaborative Group is a group of oncologists and other doctors that are involved together in making recommendations for this extremely rare disease. And because we want to make sure that it is indeed truly this rare disease, which is primary CNS lymphoma and not secondary CNS lymphoma, we recommend what is called an extent of disease evaluation. So we look at the entire brain and spine with an MRI preferably. CT scans are done when MRIs are not possible because of pacemakers or other conditions. CSF studies or spinal fluid is recommended. We recommend a slit lamp exam for evaluation of the eyes. And then importantly, a CT scan of the body is important to be obtained to rule out other areas of lymphoma in the body. We generally don't recommend doing a bone marrow biopsy. This is a lymphoma, and several patients ask this question. We now have so many good treatments, and we've optimized the treatment regimens for all of our patients. And so the median overall survival with this cancer has increased significantly in this time and age. So let's start with the treatment for newly diagnosed primary CNS lymphoma, which is also called upfront treatment. But before we go there, let's see how the treatment has evolved. In the 1980s, this disease was treated with radiation to the whole brain alone. In the 1990s, saw the introduction of high-dose methotrexate, which is a chemotherapy drug, to whole brain radiation. But after that, we noticed that there was significant toxicity and side effects with this combination. And so the 2000s saw the introduction of even high-dose chemotherapy and autologous stem cell rescue. And now in 2024, we are evaluating the role of targeted therapy and immunotherapy in this cancer. These are the recommendations by the NCCN, which is the National Comprehensive Cancer Network. And for newly diagnosed primary CNS lymphoma, they recommend induction therapy first with chemotherapy, and then consolidation to prevent the cancer from coming back. As such, the NCCN and we all recommend clinical trials as the best management for any patient with cancer. But let's start with the standard of care therapy. The goal of induction or initial therapy is to achieve a complete response. That means that we want to remove every possible evidence of the disease that we can see on MRI or evaluate on spinal fluid or on examination of the eye. And then the next part, once this is achieved, is the consolidation. So how can we consolidate that response and make sure that the disease does not come back? So 2 steps, if possible, in newly diagnosed PCNSL. Again, the goal of the initial therapy is to eradicate and remove all possible evidence of the disease to achieve what is called a complete response. High-dose methotrexate-based chemotherapy is preferred. There are various regimens that are used in the United States and all over the world. I have listed here some of the common regimens. What we do recommend is that high-dose methotrexate is used in all of these regimens if possible. And then other regimens such as chemotherapy, such as temozolomide or procarbazine, vincristine, thiatepa, and cytarabine can also be used. And rituximab is also favored now in most protocols, as well as the standard of care. Whether we choose any one of the over the other is irrelevant at this point. We don't know that any one of these regimens is better than the other. At our institution, we favor using the MTRA regimen, but any one of these regimens, as long as it contains high-dose methotrexate, is the best standard of care. What are some of the side effects that we can experience with the chemotherapy? Well, one practical aspect is that methotrexate needs to be given in the hospital, and patients need to be admitted for this reason. And the reason to admit patients is because the biggest concern with high-dose methotrexate is the possibility of kidney damage. And so in order to prevent kidney damage, we expect patients to be admitted so that they can get alkaline fluids through the vein to flush off the methotrexate and reduce the risk of kidney damage. We can also see some trouble with liver enzymes. These can be increased with some of the chemotherapies. And then some of the chemotherapy regimens also decrease different types of blood cells, such as white cells, which can increase the risk of infection, or platelets, which can increase the risk of bleeding. Fatigue can also be seen during the chemotherapy regimens. Moving to consolidation therapy after the induction chemotherapy is completed. I forgot to mention the induction chemotherapy is usually given over 3 months or so, with methotrexate infusions being given every 2 to 3 weeks, depending on the chemotherapy regimen. And then once we see that that treatment has been completed and patients have achieved a very good response, then the next step is to treat with more treatment so that we can prevent the recurrence of the disease. We know that methotrexate-based chemotherapy works really well in eradicating the disease, but it doesn't prevent the tumor from coming back. And the risk of the tumor coming back is quite high. It's about 50% within the first 2 years. And so we employ other measures after that initial methotrexate-based therapy is completed to prevent the disease from coming back. Historically, standard dose whole brain radiation has been used. This is now less used in this time and age. However, we are exploring the role of reduced dose whole brain radiation, and in many centers, this is offered to patients as consolidation. Then high dose chemotherapy and autologous transplant is also offered. And then the role of chemotherapy alone for maintenance. So what are some of the side effects that we can see, especially with the combination of chemotherapy and radiation? Well, this can cause what is called neurotoxicity, and specifically, it can cause memory changes over time. It's important to note that this memory change occurs over years and not in the immediate setting most of the time. Most people feel better when their tumor is gone. However, 2 to 5 years after the therapy is completed, patients might experience trouble with their memory, trouble with their balance, and this can be progressive. As you can imagine, the risk of radiation is worse in people that are older. However, more recently, several groups have been looking at the role of reduced dose whole brain radiation and seeing if this is actually safer for neurocognitive outcomes. The initial studies have shown that, in fact, low-dose radiation after methotrexate-based therapy is quite safe from a memory standpoint. However, we are still awaiting results from this randomized study that compared radiation to no radiation after methotrexate-based chemotherapy in terms of neurocognitive outcomes. Moving to the role of transplant. So in the early 2000s, investigators started looking at different measures to prevent the disease from coming back. And so what transplant really means is that all those patients that responded to methotrexate-based chemotherapy, we know that they're what we call is chemosensitive. So if patients are chemotherapy sensitive, clearly there must be some microscopic tumor cells that are remaining behind that we haven't been able to treat with that existing chemo, and that's why the tumor comes back. And so how would it be if we were to give them even higher dose chemotherapy, particularly with a drug called Tiatepa, and in doses that would eradicate every of those microscopic cells and reduce the risk of recurrence? Now, when that happens, in addition to killing all of the microscopic tumor cells, what also happens is that it can affect other cells, particularly cells that are produced from the bone marrow, the white cells, the platelets, the red cells that help with hemoglobin, etc. And so in order to help with this period where the cell counts go down, your own cells that are previously collected are given back. And so this is the concept of what is called autologous stem cell transplant. It's really autologous means that it's your own cells, the patient's cells themselves that have been previously collected. The chemotherapy is given, and then after that, the cells are given back to you as a rescue to cover during the period when the high dose chemotherapy lowers the counts. So because encouraging results were seen in patients with autologous stem cell rescue, this was then compared to whole brain radiation, which has previously been the standard for consolidation. And two randomized studies were conducted in Europe, and both these studies showed that the results were quite favorable on both arms, that transplant as well as radiation fared well. What everyone did note in both these studies was that with radiation, there was definitely a decline in memory over time. With regard to the transplant, there was an increase in the side effect profile, of course, and increase in what is called transplant-associated risks. And so, of course, the favorable thing to do would be to evaluate each and every individual and see how they fare with these treatments and what would be the best ideal options for that individual. And that brings me to the challenges that we're seeing with the current upfront treatments. Well, transplant and radiation clearly are ideal only for a select population. And specifically, this population include young patients that don't have other problems such as cardiac risk factors or heart problems or lung problems, and also those that have a preserved memory function to begin with so that it doesn't get further deteriorated with radiation. Again, transplant is mostly an option only for lymphoma that is sensitive to chemotherapy. And so those patients that are refractory to high-dose methotrexate-based chemotherapy, refractory means that they didn't respond as well as we'd liked to that initial chemo, they would not fare well with transplant. And then, as I mentioned, there is quite a high risk of transplant-associated toxicity and the neurotoxicity with radiation. Needless to say, there is an unmet need to optimize upfront induction therapies to reduce the risk of what we call refractory disease, those that don't respond to methotrexate, and also to cover all of those patients that cannot be considered for transplant or radiation so that everyone has good outcomes. And that brings me to older patients. I mentioned in the first or second slide that about 50% of patients are over 65 years of age. And so they may not be able to tolerate the entire extent of the intensive chemotherapy because of other problems and side effects. But I do like to mention that advanced age by itself is not an exclusion for treatment with high-dose methotrexate, especially if the renal function is adequate. That means the kidney function is adequate, then age is really just a number. And we follow all the aspects of the patient when we're trying to treat with methotrexate. I definitely would say that in my own practice, I typically do not recommend standard dose whole brain radiation in the beginning or the upfront setting because of the risk of memory changes over time. And I generally recommend to this only in the recurrence or the refractory setting if there are no other alternatives. And then I just wanted to mention that nowadays investigators are looking to see if transplant is an option for older patients. Historically, we've treated only people that are under 65. Now we extend it up to 70 to 72 years of age. And so what about those that are over 70 years of age? So this group in Europe is currently conducting a study in people who are older than 65 that are not ideal candidates for the standard of care. And if their overall function, what we call by performance status, is good, then they will consider these patients for a transplant in the context of a clinical trial. As you can imagine, the kidney function in these patients is required to be very optimal in order to be considered for transplant. So we talked a lot about treatment in the beginning in the first line setting. And so now I'm moving to what we could consider in what is called the recurrent setting or the refractory setting. So here again, I brought the NCCN guidelines slide, and you could see salvage stands for what next in the next treatment for the refractory patients and the recurrent patients when the tumor comes back. And in this case, the NCCN recommends methotrexate rechallenge. So you could give methotrexate again. You could try novel agents. Other chemotherapy could be tried. Radiation could be tried if this has not been given in the beginning. Transplant, if it's not offered in the beginning, could be tried. Again, clinical trials are the best recommendation as far as we're concerned for any patient with cancer, it's particularly in the refractory and the recurrent setting. So what are the options that are available that we could use? So temozolomide, topotecan, combination of rituximab and temozolomide, pemetrexed, these are some of the traditional chemotherapy drugs they could be used. Thiotepa in combination with ifosfamide, etoposide, and rituximab could be used. This is a tier protocol that was developed in the UK. Cytarabine and etoposide, or cytarabine and thiotepa could be combined together, followed with a transplant. Again, the caveat being the thiotepa-based transplant was not used in the first line setting. And then methotrexate rechallenge. What does this mean, methotrexate rechallenge? Basically, there are a lot of patients that had a very good response to high-dose methotrexate, and the tumor did not recur for many, many years. In this case, one could consider trying high-dose methotrexate again. And then whole brain radiation, if not used in the beginning, can also be considered. So this brings me to the role of immunotherapy and targeted therapy and clinical trials in primary CNS lymphoma, which have initially been investigated in the relapsed refractory setting, although now we're extending some of these into the upfront setting to add to high-dose methotrexate-based treatments. I won't dwell too much on this extremely complicated slide, but here are some of the pathways or the genetic mutations that we have found abnormal in primary CNS lymphoma. And with this discovery, it was quite clear that there are several targets that could be used as a means for treating patients with primary CNS lymphoma that led to several clinical trials in the last few years in this disease. I'll first start with BTK inhibition. BTK stands for Bruton's tyrosine kinase. And ibrutinib, it was the first drug in this class that was studied. This is an oral pill that is taken by mouth. What it does is that this class of drug is found to target what are called the BCR or the TLR pathways, which are active in diffuse large B-cell lymphomas and primary CNS lymphomas particularly. What is interesting to note is that this pathway is more active in primary CNS lymphoma than the average systemic diffuse large B-cell lymphoma. And so when this drug, ibrutinib, was tested in relapsed and refractory primary CNS lymphoma, the response rates were seen to be quite high, between 50 to 89% in some of the studies. As expected, the combination led to better responses. However, one of the challenges that we saw with single agent ibrutinib was that the responses were quite short-lived. The other complication that was noted was the risk of infections was increased, particularly the risk of fungal infections was increased. Now there are next generation BTK inhibitors that are being used. Tirabrutinib is the next generation BTK inhibitor, which is approved for relapsed and refractory primary CNS lymphoma in Japan based on the study that was done there. Currently, there's an ongoing study in the United States that is investigating the role of tirabrutinib in the relapsed refractory setting, as well as by adding it to methotrexate-based regimens in the upfront setting. Other next-generation BTK inhibitors that have ongoing trials in the United States are acalabrutinib and zanubrutinib, and then there are some other drugs that are also being investigated in other countries. Next class of drugs that I'll discuss are IMiDs, or immunomodulatory drugs, such as lenalidomide or pomalidomide. Some of you may be familiar with the drug thalidomide that was used many years ago and had received some that was found to have this immune effect. And since then, there have been these next generation drugs called lenalidomide and pomalidomide. The activity is quite robust in relapsed and refractory primary CNS lymphoma when it's combined with rituximab, up to responses of 60 to 67%. Again, like with ibrutinib, these are not very durable. The next line of drugs are checkpoint inhibitors. We and others found that there is a mechanism of immune evasion in primary CNS lymphoma when we look at the tissue. And so that led to trials with single-agent pembrolizumab and single-agent nivolumab. These are drugs that are used in other cancers and are being investigated in primary CNS lymphoma as well. And then this talk wouldn't be complete if I didn't mention the role of CD19 CAR T cell therapy. So these are genetically engineered T cells that target CD19, which is a protein that is found on the surface of lymphoma cells. And this therapy has quite changed and revolutionized the treatment of systemic lymphoma when it comes back. One of the side effects that were noted with this was severe neurotoxicity. And so the initial studies were not conducted in primary CNS lymphoma patients. On the right-hand side or on the top, there was a first study that was done with a compound called tesagen-leclusil. And in that study of 12 patients, the response rate was 58%. And the French cooperative group also treated some of these patients, about 19 patients, and they saw that their response rate was 74%. To mention, this was not in the context of a clinical trial, though. But both these groups found that the neurotoxicity was not higher in lymphoma patients in the brain. And this was quite substantial and helpful for us to know. We ourselves at Dana-Farber conducted a study of axi-cel or axicabtagene ciloleucel in relapsed refractory CNS lymphoma. We included primary and secondary CNS lymphoma patients here. And in our patients of 17 patients, we found that the response rate was 94%. The median time, though, to achieve a response was 3 months. And the neurotoxicity that we saw was in 41 patients, but everyone recovered from these. So what are the challenges that we're seeing with the targeted agents and immunotherapies? And this will cover, some of the side effects and the issues that we're having with the targeted agents. Well, first of all, with the targeted agents, the responses seem to be quite short and not prolonged. And so the disease, even if it responds, it comes back. And then in some cases, such as with the immunotherapies, the responses are delayed, which can be quite a problem because these tumors are in the brain and people tend to get worse until they can get better. Now, we try to reduce the neurologic deterioration by using steroids, but the problem with steroids is that they can interfere with the activity of immunotherapies, and they can also increase the risk of life-threatening infections. Then there's a concern for neurotoxicity, such as seen with CAR T cell therapy. And then there's the issue of what has always been a problem with brain tumors, that is the blood-brain barrier. So we need drugs that can penetrate the brain very well. And parts of the brain that don't have the breakdown of the blood-brain barrier, as we call it. Combinations of these agents, either with themselves or with chemotherapy, is extremely essential, and this is what is now being studied in the context of clinical trials. Here's a slide. It's quite a busy slide, but this sort of shows us the landscape of all of the trials that are currently being investigated in relapsed and refractory and upfront primary CNS lymphoma as well as secondary CNS lymphoma. What I'd like to mention is, as someone who's been seeing these patients for about 15 years or so, the number of clinical trials in the last few years has significantly been higher, which we're very happy about ever since we understood the biology of this disease a bit better. So with that, I'll conclude. Primary CNS lymphoma is a distinct disease. When I say distinct, it's very different from systemic lymphoma. It has unique targets that are not seen that commonly in systemic lymphoma. The prognostic factors are age and how patients are physically. However, we are now looking at molecular features to see if the genetics of the cancer itself can tell us more about how patients do, particularly if they have a specific response to certain treatments versus not. We do recommend early diagnosis when there is a suspicion for primary CNS lymphoma and starting the therapy very quickly to improve neurologic outcomes. High-dose methotrexate-based chemotherapy currently remains the standard of care treatment for newly diagnosed primary CNS lymphoma, and Thitepa-based transplant is recommended for those that are eligible for consolidation. Ibrutinib and lenalidomide have been included in the NCCN guidelines for relapsed and refractory primary CNS lymphoma. And CD19 CAR T cell therapy is under investigation, and so are other BTK inhibitors, and we're hoping more from some of the new treatments to improve outcomes for our patients. I'd like to thank all of my collaborators in the different multi-centers that makes this a better effort. The funding sources for all of my research, and above all, patients and families for their contribution and for everything that I learned from them. With that, I'll take questions.
Thank you so much, Dr. Nayak. Just as a reminder, if you have questions that you'd like to ask, please type and submit it using the Q&A button, and we'll answer questions as time allows. So one of the first questions we have here comes from a survivor, and they would like to know if there is a standard of how often they should be getting checked for recurrence and what that looks like. What do the follow-ups look like? Is it MRIs? How often should those be?
Thanks, Umbreen. That's a very good question. So routinely, we recommend, and so does the IPCG, based on the guidelines, to do MRI follow-ups every 2 to 3 months for the first 2 years. The interval between scans can be increased after that. We do recommend continuing follow-up for at least a period of 10 years. And part of the reason for recommending MRIs more frequently in the first couple of years is because the risk of recurrence is the highest during that time. We also want to pick up disease before patients become symptomatic so that we can act on it and prevent neurologic deterioration.
Thank you so much for that guidance. Um, on the question of reoccurrence, I know you had talked about it being highest within those first 2 years. For patients who have undergone a stem cell transplant, is that recurrence rate lower, or can you talk about the statistics and survival rate for patients who have had a transplant?
Absolutely. So, based on the studies that we have so far and based on long-term follow-up, so long-term meaning up to 8 or 9 years of after stem cell transplant studies, the risk of recurrence is quite low in patients that have undergone a stem cell transplant. And at 8 years, it's down to about, I would say, those that underwent a transplant at 8 years, there was a did not have a recurrence in 60% of patients. So 40% of patients recurred. And the majority of patients were alive and well despite having recurred as well. Meanwhile, when you haven't had a transplant, the risk of recurrence is about 50% in the first couple of years. So that's quite different. That being said, in the studies that did look at transplant, those that recurred within the first 2 years. So there's a small fraction of patients that did undergo a transplant that recur in the first 2 years. The risk of recurrence after that then decreases after the transplant.
Thank you so much. We have a question here asking if you can give maybe just a quick overview of what that stem cell transplant process looks like for a patient, from the point of retrieving the cells to when they're getting into recovery.
Right. So there are several steps involved in this, and first requires is there eligible? How is the eligibility of that individual? So how fit is the individual? So age, of course, matters, but other than the age, we look at how the status of the heart is. We look at how the status of the lung functioning is, because some of these chemotherapies can be quite toxic and damaging to the heart function and the lung function. And so we'd like to make sure that patients do really well. After that, we actually look for risk of infections as well. And so if there are any brewing dental abscesses or any you know, tooth issues, we have a dental follow-up as well. And sometimes the dentist might recommend either a root canal or removing the tooth so that there is no brewing or minor infection that is lingering in the body before going to a transplant. Once all of those things are done, patients would get some treatment that would boost their immune system so that the cells can be collected. And then once the collection is done, patients are admitted to a transplant unit, of course. This is a very specialized center, and only special different hospitals can have these transplants. So not every hospital that can deliver chemotherapy has the capability of undergoing a stem cell transplant. So some patients might have to travel in order to undergo the stem cell transplant to a transplant center. In the hospital, depending on the specific regimen that is used, that may include THI-TEPA, the chemotherapy may be given over 3 days or 5 days. And then after that, the cells are given. And then the next part is really the period of waiting when the counts drop. And the counts, of course, will drop. And sometimes during this period, people can have infections and other side effects. And people can get quite weak from this. And most patients, they'll recover their counts at about 3 to 4 weeks after the chemotherapy is given and are discharged at that time. But the first 100 days or so, so the first 3 months after the transplant, are very critical in monitoring and close follow-up.
Thank you so much for providing that realistic expectation of what a patient may go through when they're undergoing an autologous stem cell transplant. Can you talk a little bit about the value of second opinions? Do you recommend a newly diagnosed patient to receive a second opinion? And at what point would you recommend for them to get that second opinion? Is it at the point of diagnosis? Would it be at the point of relapse? What's your opinion on that?
So I think that a second opinion, especially in rare diseases, is extremely important. And, you know, in the newly diagnosed setting, that there are different challenges, which I'll come to in just a second. But particularly in the relapse setting, it would always be beneficial to get a second opinion. And even if that individual that they're seeing is an expert, personally, it's always, I'm happy when my patients are getting other opinions as well. That being said, timing is very critical. And, I always say this to my patients, and when I'm teaching the the graduates, I'm always using this term, time is brain. This is a terminology that we use for strokes. However, this is something that is very critical in primary CNS lymphoma as well, because the sooner we could start treatment, the higher the possibility of neurologic recovery. And because we can see neurologic recovery and we can prevent permanent damage, it's sort of a balance between, do you have the time to get the second opinion, or would you rather start the therapy? And I think that can be a bit difficult to assess at that time. If there is time, if there is stability, it's helpful to get a second opinion. But if there is the utilization of standard of care treatments and there is a decline neurologically, I would definitely recommend starting the methotrexates sooner than later.
Thank you so much. We have a question here from, it looks like a caregiver caring for their parent, and they underwent high dose methotrexate, and they're curious to know at what point after the chemotherapy has been completed is it the patient ready to travel again, or is it considered safe for them to travel again?
So travel safety has several aspects to it. With the induction chemotherapy, that is high dose methotrexate based chemotherapy, most of the time the immune system is relatively reasonable in terms of count. So, you know, it's possible to travel. I would say that our definition of what was okay with travel changed after COVID. Things are definitely better now with regard to recovery and the COVID vaccine. So I think we as oncologists and patients too themselves are becoming more um, favorable as far as, being on airplanes and things are concerned. So one aspect is the counts. So how is the immune system? Is there a risk of infection, acute infection like respiratory infections, etc.? And then the second part is, how large is the tumor? And is there a risk for flying with regard to that? And what would be safe in that regard? How much do you want to travel? How far away do you want to go? Is it going to involve a period where it's going to interfere with the every 2 week cycles of chemotherapy? Those are some of the factors that one would consider. And this can be discussed with the doctor in terms of traveling.
Thank you so much. Another question we have here is asking, once the patient is in remission, is there anything else that can be done to try to avoid relapse? Is there anything else you as a provider would recommend doing? And is there anything the patient can do proactively that may benefit them?
I think that once the consolidative treatment is done, the only thing is really follow-up and imaging. And of course, I always advise that if there's any concern or a slight hint of symptoms that are persistent in between the MRIs, then I recommend them letting their doctor know so that an earlier MRI could be obtained based on what those symptoms specifically are.
Thank you so much for that advice. One more question we have here about the stem cell transplants. If a patient has already gone through an autologous stem cell transplant and then had a relapse, are they eligible to have another transplant? And if not, why would that not be a consideration?
So this is a tricky question to answer. So that would depend on how long ago the transplant was, what were the agents that were used with regard to the high dose chemotherapy, and if there would be a value in repeating it. The other part is that these are not trivial treatments. Um, and, with age, the body tends to feel the effects as well. Um, we are also now looking at some studies to look at the genetics of the bone marrow function itself and peripheral in blood, so that it's helpful to know if there's risk of other types of cancers, such as leukemias, that can occur as a result of heavy duty chemotherapy that's given later on in life. So these are some of the risks, that can occur with recurrent transplants. And again, the main thing though really is if it failed the first time, how quickly did the tumor come back? And if it came back quickly, then doing it again is probably not the answer.
Thank you so much for that thoughtful response. I think we have time for just one last question. And this one is asking if you are aware of or if you can share any statistics for healthy younger patients, patients who are 45 or younger, in terms of prognosis, survival rates, anything like that.
So the transplant studies have the best data on younger patients with regard to survival. One thing is that um, younger patients, younger than 40 or 60, depending on which scoring system we use, but the younger people are, the better is the prognosis. We know that it's one of the most single um, independent prognostic factor. That being said, after going through a transplant, the chances of the tumor coming back in a younger patient are definitely lower. We don't know whether this is related to the specific genetics of the tumor itself or related to age itself or not, but this is just an observation. And the 10-year survival rate is close to 80% in anybody younger than 70 at with an auto transplant.
Thank you so much, Dr. Nayak. That is all the time that we have for questions for this session. Again, I want to thank you, Dr. Nayak, for taking the time to share your insight and expertise. Thank you to our webinar sponsor, Ono Pharma, for their support of this program. And of course, a special thank you to each and every one of you for joining us online today and sharing your questions. We hope that you have found this webinar to be informative and beneficial. We encourage you to take a few minutes, mobile phone, or going to the link on the screen. Your feedback is important to us as we plan for future programs. You will also receive a link to complete the survey along with the webinar recording in a follow-up email message in the next few days. If you're looking for more content like this, please check out our next webinar, How Metastatic Brain Tumors Affect Your Melanoma Care, presented in partnership with AIM at Melanoma and the Melanoma Research Foundation. This webinar will take place May 9th at 1 p.m. Central Time. For more information about ABTA's programs, events, and services, visit ABTA's website at abta.org, email us at info@abta.org, or call the ABTA Care Line at 1-800-886-2000. 2282. This now concludes our webinar. Thank you so much for joining us and enjoy the rest of your day.